Okay, so I'm going to go ahead and get started. Again, welcome everyone. Good morning, good afternoon. Welcome to our session titled Prioritizing Investments in Pre-Service Health Education in Sub-Saharan Africa, a Human-Centered Approach. Before we get started with our presentation, I have a few housekeeping rules and instructions that I wanted to share. And before I do that, I also wanted to introduce myself. My name is Anam Bhatti. I am the Technical Development Officer with USAID's Momentum Country and Global Leadership Project. And I will be handling the logistics and some of the back end technical kind of duties on this presentation. So if you have any trouble with your sound or any issues, please feel free to direct message me in the chat. So for our presentation today, we have interpretation for French and English for the first 2 hours through our interpretation service. To access this interpretation service, you will see a globe at the bottom right corner of your screen. If you click that globe, you will be able to select your language. So feel free to select English or French. And after you click your desired language, you can also mute the original audio. That way you will only hear your language. I will stop here for a moment and have Nicole translate my instructions into French for our francophone speakers.
OK, bonjour à tout le monde. Excusez le français, c'est un peu difficile pour moi, mais pour que vous pouvez écouter les vrais interpréteurs, cliquez sur la petite icône d'interprétation, c'est un globe, et vous pouvez choisir votre langue. Et aussi, si vous ne pouvez pas écouter les voix, vous pouvez cliquer sur Mute Original Audio. Comme ça, vous pouvez écouter seulement la voix de l'interprétateur. OK? Excusez-moi, le français, c'est pas parfait, mais j'espère que tout le monde peut choisir la langue de votre choix maintenant.
Great. Thank you so much, Nicole. And I also want to note that we do have our chat feature, so feel free to drop any questions or comments throughout our presentation into the chat feature as well. I will, and then one last message here or a plug. We also encourage you to visit the CUGH website, and I will actually drop the link into our chat in a moment for you to visit this website as well. And with that, I will hand it over to Francis.
Hello, everyone, and thank you again for joining. Good morning, good afternoon, good evening. You are welcome wherever you are joining from. We are delighted to have you join us as we share some highlights of this very exciting work that we've been doing the last couple of years and are continuing to progress on. Next slide, please. So my name is Frances Ganges. I'm a senior maternal newborn advisor at JPIGO, working with the Momentum Country and Global Leadership of USAID. We want to acknowledge before we begin our supporters, funders, and partners. As you see here on the screen, we have quite a few. First, to acknowledge our supporters, USAID, United States Agency for International Development, Momentum Country and Global Leadership, specifically in USAID, the Africa Bureau, who is supporting these great efforts. We also have a number of partners which we worked with in Africa, the East Central Southern Africa College of Nursing and Midwives, ECSACON, the Francophone African Fédération of Midwives Association, FASFAF, and the West African College of Nursing and Midwives. We also have been working very closely with the Johns Hopkins School of Nursing, who has been a very close partner in this effort. and the African Forum for Research and Education, AfriHealth, and PACT, who are our partners also in capacity development. So we wish to thank all of them, without which none of this would have been possible. And we look forward to sharing with you, and you'll be hearing from many of them during this presentation. Next slide, please. So this is an outline of our session overview. We have quite a packed program to share with you today, and to look forward to you engaging with us. We will start off with talking about the whys and, just sort of the background of this effort and where our vision derived from, looking at some of the global issues and the global strategies and evidence from which we derive this project. And then talking a little bit about the how, the human-centered design approach that we've used throughout this engagement. And then we will share some details about the Momentum Country and Global Leadership, Strengthening Midwifery Education in Africa. And that is where we will delve into some additional details about some of the tools that we've developed. And lastly, and most importantly, we will have a session. Our third session will focus on a sort of pilot session where we would like to engage you to look at how we've been developing our educational capacity frameworks, and to engage you in utilizing them, a short session to utilizing them and to giving us your input and feedback. Next slide, please. So again, you are welcome. And we know that you've come from various universities and countries and different places. So we'd love to hear from you. If you would use the chat box to let us know your name and your country. We would love to hear where you're coming from or where you are based. Ask you to do that in the form of a chat. Now, please, if you are logged on, we ask that if you are not presenting or speaking, if you would please mute your microphone. And also we are looking forward to using the chat function throughout this presentation. For example, if you have a question, please do utilize the chat function for that purpose. So please put your name and country. Looks like we are having some. Great. Liberia, thank you. You're welcome. Malawi. Welcome from Malawi. Welcome from the US. Nigeria. Thank you, Nigeria. Botswana, you are welcome. Thank you. So please continue putting your names, country you're from. Guinea, thank you for joining. We're very interested in where you are from, and Kenya, Ghana, Guinea, thank you. We're very interested in hearing from you. So please continue even throughout the session to put your name as you join and where you are from. New York, USA. Thank you very much. And we know that we know that a lot more of you have registered, and perhaps people haven't joined in yet, but we will continue to remind you to let us know who you are and where you are from. Thank you. Next slide, please. So we would love to hear from you also about where you, not only where you are from, but what your discipline is. Are you a midwife? Are you a physician? Are you an advocacy professional? You're an instructor or professor or teacher of some type? Anam, are we going to do this in a poll, or are we going to do this in the chat?
So Francis, unfortunately, our poll feature is not available, so we will conduct this through chat, and I will actually drop in the full question as well as some options for answers.
Great, great. We apologize that the poll function is not working. We've been having some technical difficulties, but that's okay. We'd still love to hear from you. Please put in the chat, whether you're an educator or what your discipline is and what your specific role is at this time. So thank you. We would love to hear about that, your primary profession, and and what your specific role is. Thank you. I have a student midwife in the room. You're welcome. So please continue to do that. Since we got started a little bit late, we want to continue with moving along. Thank you, nurse, educator, lots of educators in the room. You're very welcome. We also want to acknowledge, in addition to our partners, we want to acknowledge the schools that we are working with in this effort. So we have a school in Botswana, in Togo, and in Ghana, which you'll hear more about later on in the discussion. So at this point, I would like to turn over to my colleague, Nancy Reynolds. Nancy, you're welcome, and thank you all.
Thanks so much, Frances, and welcome everyone. It's a real pleasure to see you. So glad you were able to join us today. And again, my name's Nancy Reynolds. I'm a professor and associate dean of global affairs at the Johns Hopkins School of Nursing, and I've had the pleasure of being a part of this project over the past 2 years. And I'm just going to take really just 2 minutes to put our objectives today into the broad context of global goals and the SDGs. And as you're all aware, the SDGs are 17 interlinked goals adopted by the UN in 2015, and they're really designed as a blueprint for a better and more sustainable future. Next slide, please. And as you're aware, the SDGs are really an ambitious set of goals that are really built on decades of work by countries and the UN. But these really come with a strong recognition that the goals are very interdependent. And among these strategies are strategies to improve health and education. Next slide, please. And that's really where this project comes in. It's about investing in pre-service education, and this is an investment in the midwifery workforce, and the healthcare workforce is so critical to the achievement of the SDGs. And midwifery in particular is critical to achievement of the SDGs because the work of midwives is to support women of childbearing age, including adolescents, during pregnancy, birth, and throughout their lives. And it intersects with numerous ways with the SDGs. And just to give you a couple examples on the final slide, SDG number 3 is about health and well-being, and specifically related to midwifery, reduce global maternal mortality ratio to less than 70 per 100,000 live births, ensure universal access to sexual and reproductive health care services, including for family planning, information and education, and the integration of reproductive health into national strategies and programs. And then SDG number 5 is about gender equity, and investment in midwifery is investment in gender equity because of the whole approach of midwifery to the care of women, which is about respect and respect for how a woman experiences care. So now it's my pleasure to welcome my colleague, Pandora Hartman. Thank you.
Thank you so much, Nancy, for beginning to set the stage. I am Pandora Hartman, Chief Nursing and Midwifery Officer for JPIGO, proud nurse and midwife. I think all of us here today would agree that investing in nurses and midwives is a good value for money. Highlighted by a report by the UN High-Level Commission on Employment and Economic Growth, which concluded that investments in education and job creation would result in that triple return that we've all heard about. But I think what gets in the way is sometimes we're not clear on what that definition of investment actually is going to look like. So I'm going to highlight a few documents that any of us interested in these nursing and midwifery health workforce should have in our toolboxes as we advocate. You see this, Agenda 2063. This is Africa's development blueprint to achieve inclusive and sustainable development the next 50 years. adopted in May 23 at the Golden Jubilee of the African Union. So this sets out regional and national objectives through 5 10-year implementation plans, the first of which is undergoing now, spanning 2014 to 23, which outlined goals and priorities and aspirational targets for the continent to achieve the Africa that it wanted. So can you go back, please? Thank you. The Africa that they wanted. So the aspiration based on the prosperous and inclusive growth and development, high standards of living anchored on high quality and inclusive health education driven by science and technology. What can we say? They paired it quite together, didn't they, with the aspiration and the goal for a high standard of quality of life and educated and healthy and well-nourished citizens, which are some of the goals as well. We can say that the continent is doing quite well thus far towards that goal of a healthy and well-nourished population, explained a lot by the increases in COVID funding that have been out there, which also had a spillover effect, as we know, on the overall health of the country. Substantial increase as well in SRH. They say when they're measuring this, it's at a 77% increase to reduce this. So in a nutshell, Africa is well on its way to 2063 with midwives as a key force. Next slide. So as we link what's happening nationally to global, you guys, I know, are familiar with these numbers that we looked at to attain adequate systems. Over 200 experts coordinated on this particular document to consolidate the evidence around what a comprehensive workforce actually looked like. This policy document outlines policy options for member states, non-member states, any interested actors to optimize health workforce and progress towards the UHC and the SDGs, which Nancy outlined so lovely. And to help us also understand and prepare for the future needs of health systems to really harness that rising demand and maximize job creation and growth and strengthen that data. So, you know, what do we know about this? That investments in health workforce is lower than we actually often think about because of chronic underinvestment in education and training. And many times because of the mismatch between health systems and population needs with continuous shortages. It's really interesting that despite the shortages which we're aware of and distribution challenges, that we know there's sometimes a paradox of health worker underemployment, even though we have major existing health needs. So where does that leave us? There's one slide that's missed out here, but I want all of you to go to the ECSA labor market for nurses, which the region in partnership with JPIGO and the World Bank, we took a really deep dive to look at some of these issues through a mixed method approach to really look at how nurses and midwives are working throughout 2030. And what we found is not a surprise, is it? That we needed to emphasize primary care, that we needed to regulate and codify the role of the advanced practice nurse, and that we needed to ensure high quality and transformative educational models while investing in competency-based, practice-oriented, transdisciplinary learning, and ultimately to strengthen nursing and midwifery education through innovative and robust models, which include all sectors, both private and public. And with that, I think that's a really good segue in setting the stage to hand over to our colleagues and friends at ECSACON to take it to a little bit of a next level. Kio, over to you.
Thank you, Pandora. Good morning, good afternoon, good evening, wherever you are, ladies and gentlemen. I hope you can all hear me. I'm going to be sharing with you the implications for nursing and midwifery, but I will particularly look at midwifery because today we are talking about midwifery. We all know that midwives provide essential clinical interventions, which are very good in advancing universal health coverage. And as such, midwives are playing a very vital role in preventing maternal and neonatal deaths, as well as mortalities and morbidities and stillbirths. therefore, increasing competent midwives is very important to save a lot of lives. I will just take you through some research that is done and some literature. According to the WHO Strategic Directions for Nursing and Midwifery of 2021 and 2025, it has shown that education is a policy priority. Education in midwifery, like I've already said. So this strategic directions stresses the need for dialogue about investment, that the investment should be considered very seriously at country level as well as at global level. Although research has shown that midwifery is very important, we still see that midwifery is very grossly underfunded. And this underfunding of midwifery is leading to midwifery therefore having a lot of variations in different countries. Variations in terms of content, in terms of quality, in terms of duration. So that is why today we are talking of investment in midwifery to make sure that midwifery is standardized. Midwifery is at international level across the globe. Can you move to the next slide, please? And also, according to the State of the World Nursing Midwifery Report of 2021, it also agrees with the strategic directions of WHO that education and training is key investment area. In Africa, it has also, research has also shown that most of the maternal deaths, like I've pointed, and the neonatal deaths occur in the Sub-Saharan Africa. And as a continent in Africa, we need to look and take investment in midwifery very serious. It is also shown that there is a critical shortage of midwives, which is very true. Now we are saying, let us consider increasing midwifery in terms of training, in terms of education, in terms of looking at the infrastructure. Because when there is little infrastructure, where there is little resources for midwifery, we tend to see the students of midwifery not gaining that opportunity of having like clinical practice where they can gain more skills. So that is why we are bringing in this to say Africa and the globe at large, let us consider investing in midwifery. There are many areas that we can look at to invest in midwifery at. We are particularly talking about education, but it's not only education that needs to be invested on, but we are just saying we need to increase midwives, we need to increase competent midwives, we need to increase midwives who are trained at international level, we need midwives who can work everywhere without any problems. Because like I stated that when there are variations in terms of content, you will find that some countries may just decide to train 1 year, others 6 months, and then they say they have produced a midwife. So we are saying, let us produce competent midwives, let us produce midwives who will work solely and make decisions. And also look at investing in areas of midwifery leadership, whereby we are saying midwives should also be at that decision-making level, whereby they can push the agenda of investing in midwifery, looking at the limitations that midwifery has right now. So I think this is what I just wanted to show you and emphasize that there is really a need for investing in midwifery. Can we move to the next slide, please? Yeah, so that is what I was sharing with you, and I will right now hand over to my colleague Etta to continue with the presentations. Thank you. Over to you, Etta. Are we together?
I think Etta might be having some connectivity issues, so we can give her about a couple of minutes to join us.
Okay.
Perhaps while we are waiting, I could interject here. I want to thank you, Keo, for your presentation. And indeed, these important global documents have come to many of the same recommendations and conclusions regarding midwifery education. Midwifery education is one of the key areas and one of the agreed upon areas that need our time and our attention in this coming decade as we look toward 2030.
So it seems that Etta might not be able to join us. So may I ask Keo if you're able to present on the literature review?
It's fine. I will take over for Etta's presentation. We can continue. Thank you once again. Let me just give a pre-service midwifery education overview, or just a summary of what I was just talking about. In Africa, according to the research or the documents that I have shared with you, it has shown that there's poor alignment of international standards and school capacity. Like I've said, that there are variations in terms of duration, in terms of quality, and so on. And also poor communication and collaboration between schools and clinical sites. Obviously, we are saying midwives need to gain practice or hands-on practice. That is, they have to move from the class to the clinical sites. But there has to be good communication and collaboration between these two areas, because the midwives are gaining from both sides. So this communication also is something that has been identified as a problem. There is an inadequate number of strong preceptors. We know that at the clinical sites, these students, they need mentorship, they need preceptors who will take them through. Because if we only look at the teachers or the tutors in the class, some of them also, they don't have enough practice to show the students. The students need people who will actually take them through on practical sides. There is also a gap identified in technology integration to promote access. We know that nowadays technology is the most important factor that the students, the teachers, and everyone should be able to engage in. There are some gaps identified in the literatures, not only the two documents, but there are many literature that has shown the gaps of infrastructure, management, deployment, faculty, and so on and so on. So these gaps, they need to be closed. Move on to the next slide, please. Yeah, so that map is just to show the countries, those countries and partners that are here with you today sharing these presentations. So I think from here, move on to the next slide.
Here, If we could just share some perspectives from each of our partners, I would like to hand it over to Madame Eloise to share some of her perspectives from her region.
Okay, thank you.
Bonjour à tous. Je suis Héloïse Adandobou d'Almeida. Je suis la présidente de la Fédération des associations des sages-femmes d'Afrique francophone qui regroupe 17 pays. Je suis très heureuse d'être sur cet appel avec vous et je m'en vais, à l'instar de mes collègues qui m'ont précédé, vous parler des défis qui minent la formation initiale dans notre région francophone. Alors, le tout premier défi, c'est l'inadéquation des infrastructures pour l'enseignement en approche par compétences. Il y a aussi une insuffisance des ressources matérielles. Les écoles de formation ne disposent pas de modèles anatomiques humanisés pour permettre l'acquisition des compétences en salle des apprenantes avant d'aller sur le matériel humain. Il y a aussi une insuffisance créée de laboratoires de compétences. Les laboratoires de compétences, ce sont ces salles de pratique qui disposent de modèles anatomiques humanisés, comme je l'ai dit plus haut. Et il y a une insuffisance de ressources humaines qualifiées. Les formateurs théoriques dans les écoles n'ont pas la qualification indiquée et les précepteurs ou les encadreurs sur les sites cliniques aussi n'ont pas souvent la compétence requise pour bien encadrer les étudiants qui vont en stage clinique. Il y a aussi une insuffisance des sites de stage clinique. Vous savez que la formation initiale est faite de formation théorique et pratique et la plupart du temps, les sites, les hôpitaux, les formations sanitaires qui accueillent ces élèves-là ne sont pas suffisants pour couvrir l'effectif qu'ils sont. Il y a aussi le non-respect du ratio apprenant-enseignant. Dans la formation sage-femme, il est indiqué qu'il faut un formateur pour 15 maximum apprenants, alors que là, les apprenants vont jusqu'à 30, 40 par enseignant. Il y a aussi le défi majeur pour que les écoles soient reconnues, soient accréditées, ou que le parcours de l'accréditation soit initié, c'est le rattachement des écoles de formation initiale au ministère de l'Enseignement supérieur qui reste dans l'espace sur les 17 pays, à peine une dizaine ont cet avantage-là. Merci infiniment. Je peux m'arrêter là et passer la parole à ma collègue suivante. Je vous remercie.
Thank you for your perspective, Eloise. We are interested. We are very interested in hearing more about that as we move on with the session. Eloise was giving her perspective on what the experience is in the region after you saw that summary of our literature review about midwifery education in Africa. Thank you very much.
So at this time, we will have a discussion based off of what was presented. And so we will open it up to our larger audience to drop in questions in the chat box. And myself and Nicole will help to facilitate that on our end, and we'll hand it over to Francis.
Yes, please do drop any questions in the chat box. We'd love to hear from you. If you have any questions about what we've presented thus far, we will certainly be going into further detail. May we ask our colleagues to mute if you're not presenting or you have a question, but please drop your question in the chat box and we'll be happy to try and address them.
Well, I see one question here, Francis, which is what's the impact of private schools on the quality of pre-service education?
Thank you. What is the impact of private schools on the quality of pre-service education? In many countries on the African continent, the majority of the schools are government or public schools. And however, there's a rise more and more of an increase of private schools that offer pre-service midwifery education. What might that be? Perhaps we can talk about that if you want to put in the chat. In your country or in your locale, what is the impact of private schools on the quality of pre-service education? Have they impacted midwifery education in your settings? And if so, how?
Yeah, and I see that Beatrice has her hand up. I don't know if she has something to say in relation to that or another question, but.
Beatrice, we'd love to hear from you. Did you have a question or did you have a comment?
Hello.
Yes, Q.
Yeah, no, I just wanted to touch on the question that is asking about the impact of private schools on quality of pre-service education. There's also another study that we did, ECSACON and the PIPE and the World Bank, that we did on the nursing education and labor markets. That study also proved that private schools have a very good impact in pre-service education. The problem that came out from that study was that, you know, private schools are a bit expensive, but unfortunately, most of the time, the government does not pay for the students who go to those schools. So as such, sometimes the quality of those schools also is not monitored in a way that, you know, like I earlier on said that there are some variations in the content. So in a nutshell, private schools would also have a good impact provided the government took the responsibility to make sure that those schools are licensed, they are accredited, and even the course content is also accredited. So also it would help to increase the number of midwives, which we are currently crying about. So it's not only the government which can manage to bring the right numbers that we want. We can also get from the private schools, but there were those hiccups that came out from the study, but private schools are also very critical in pre-service education.
Oh, thank you. I see Beatrice has her hand up again, and Beatrice, please make your question or comment. You'll need to unmute though. Oh, there we go.
Okay.
Yes, thank you. Please.
C'est Béatrice en RDC. Je suis directrice de projet RHS, Resilient Responsive of Health System, en RDC avec Columbia University. Je voudrais partager l'expérience et je suis très contente de ce forum, de cette conférence. Ça me rappelle de tout ce que nous avons fait avec le projet NEPI Et quand je vois celle qui a partagé pour la dernière fois sur les challenges of midwifery, alors j'ai dit que c'est exactement ça. Et ici en RDC, avec les écoles avec lesquelles nous avons travaillé, on a vraiment levé ces défis et ces écoles se sont améliorées par rapport à l'absence des précepteurs qualifiés, par rapport au curriculum. On a revu le curriculum de formation des sages-femmes. On a donné des matériels, on a doté des matériels, des clinical simulation lab, et ça a vraiment amélioré. C'est juste cette expérience que je voudrais partager pour dire que ce n'est pas encore tard en Afrique pour que nous puissions améliorer la formation des sages-femmes ainsi que celle des infirmiers. Mais c'est plus pour les sages-femmes parce que les sages-femmes sont moins nombreuses par rapport aux infirmiers. Merci beaucoup. Hi, everyone.
Thank you very much for.
Did you catch me because I was talking in French according to the last presentation? I don't know if everybody understood me.
Well, maybe you could repeat what you said in English too. I know.
Thank you very much. Sorry for my English. I am French speaking, but let me try talking in English. I was saying that this conference is very interesting for me, and I'm very happy for this. And let me share my experience in DRC, because we worked with the NEPI program, and the causes of midwifery challenge are the same like here in DRC. But we resolved all of these problems according to NEPI support. It means we revised the curriculum, the related curriculum of midwifery, and we provided some materials in the selected schools, including clinical simulation lab, material for technical room, the textbooks, and we trained faculty members on competencies-based, curriculum competencies-based, and we noted that more things changed positively. And we are very happy for this. That is just to share my experience from DRC on midwifery challenges, education midwifery challenges. Thank you very much.
Thank you so much for sharing those comments. And it sounded like with the investment of resources that it was helpful in building the capacity of midwifery in the institutions involved. I did, when you were speaking in French, you did mention something about the faculty too, and the need for strengthening the skills of the faculty is an important component of it as well, correct?
Yes, here also we strengthened the faculty members. Faculty members were trained in curriculum-based competencies and all the challenges. They was trained, and for now, they can do a good job.
Yeah, I find that in some of my international work that often there's a great deal of emphasis on the curriculum and the preparation of students, but without thinking about the importance of the faculty piece too and the strength of the faculty. So I appreciate that comment.
Okay.
Yeah, Francis, do you have anything to add? I know we are.
Thank you.
Oh, yeah, there you are.
Sorry, I was on mute.
Oh, yeah.
Thank you very much, Beatrice, for your contribution. It's really good to know that the challenges are not limited to only a few countries, but that we're sharing many of the same challenges. I do think there was another question in the chat, and perhaps our midwifery partners can respond to this. What was the level of collaboration between Anglophone and Francophone midwifery organizations before this work? So before we started this work in the last couple of years, what was the level of collaboration, for example, between FASFAF and WACN and ECSACON? Would our regional partners care to respond to this question, please?
Hello.
Yes, please, Keo, go ahead.
Admit from my own point of view that there hasn't been collaboration between us as a college and the other colleges. Because to be honest, I remember even myself when I came into office, I tried, actually I only knew about West Africa College of I wrote to them, there was no response, and you know, then I just gave up. I just want to say we haven't had, unless maybe a working relationship between the colleges and so on. The only time I happened to meet one of my colleagues from West Africa College of Nursing was when we were brought together by JAPIGO.
I think we are losing some of your audio, Keo. Is anyone else having difficulty hearing?
Yeah.
Okay.
We have another hand up here.
Eloise, I think you raise your hands. Please go ahead, Eloise.
You're on mute, though.
Merci beaucoup. Est-ce que j'ai la parole?
Oui, allez-y.
Merci beaucoup. À la question de savoir quel partenariat il y a entre les regroupements régionaux. Je voudrais juste dire qu'il n'y a pas de cadre formel, mais au cours de nos rencontres organisées dans la région par ICM ou par la Fédération des associations des sages-femmes d'Afrique francophone auxquelles nous convions nos collègues, nous avons des discussions franches sur ces défis et nous échangeons sur les éventuelles approches de solutions à partager, étant donné que nous sommes en Afrique et nous avons pratiquement les mêmes réalités avec certaines spécificités. Et je peux dire aussi que le cas du MCGL là nous a permis de nous confronter vraiment et qu'à partir de là, on va formaliser les choses pour que dorénavant, les expériences qui seront vécues de part et d'autre soient partagées et que nous ayons une vue d'ensemble sur comment régler ces problèmes-là que nous avons identifiés. Merci.
Thank you, Catherine. I don't know if you would mind summarizing Eloise's comments. We had some difficulty with our audio. We weren't hearing you very clearly. It was very spotty. If you wouldn't mind, if you would type in English the translation for those in English. Thank you very much. Do we have another hand up, or let me see?
No, there's a comment in the chat box in Uganda at the home doctors in Uganda. The medical doctors review and assess pregnant mothers, come up with plans of management, and then the midwives provide individual care, especially around postnatal and neonatal care. And I don't know if that's true for the whole country all the time, or if it's just the practice of that particular entity.
I think he was mentioning the practice of that particular organization. Thank you. Thank you for your comment.
Okay, great. So at this time, we will take a short break. We have only a few minutes before we begin our next set of presentations. So we will take a break until the top of the hour, and then we will come back and discuss solutions as well as our human-centered design approach. Okay, welcome back, everyone. I will hand it over to Palelo to help us get started with our next set of presentations. Palelo, over to you.
Thank you so much, Anam. And thank you, Francis and Nancy, for such an interactive session, which we just finished before we went for our break. My name is Palelo Marole. I'm Regional Senior Technical Advisor working for JAPIGO, and I'm based in Botswana. Next slide, please. We're going to talk about strengthening midwifery education in Africa, the project that we have talked about. We have reviewed the importance of pre-service education. We have discussed some of the challenges, and we have heard our leaders discussing and bringing up those challenges that we are facing in Africa. I'm just going to describe our approach to this issue. And I will start with an overview of the project. Our work started with a landscape analysis of the pre-service education in our Sub-Saharan Africa. And our work was guided by the model that you see on the PowerPoint. This model here depicts the components of pre-service education, and these domains are the domains that are required for a competent midwife. On the left, on those colored domains, you see all those domains that are required and are involved in midwifery education. And these domains, for the midwife to be competent, these domains have to be addressed and have to be at least reviewed and have to be at least very, very efficient and effective. If these domains are not addressed, and these domains, if they are not addressed, there will be a gap in the area of competencies for midwives. And these domains are also a potential area for investment. If there is limit or if there is a gap in these domains, we can identify a gap and have that gap as an area of investment. So we use this model to guide our project. And as you can see on those colored things, we have clinical practice domain, we have students, we have the teacher, the tutor or preceptor, we have infrastructure and management, and we have curriculum. If all those domains are not addressed, the competency of the midwife will be affected. So for our first year of the program, our deliverables included, as already discussed by our partners, we conducted a literature review and we completed a midwifery education inventory. And we are hoping that we will come up with innovation or innovative strategies to guide investment. We hope that whatever we will identify from the literature review and from the inventory will help us come up and will guide our investment for pre-service education. Next slide, please. And these are the highlights for the inventory that we did. Self-reported information, such as a type of program, the accreditation status. We're also able to see the graduation rates. 31 countries participated in that inventory, and 100% from the West, 88% from FASFAF, and 73% from ECSACON. And 76 of the countries reported the WACN accreditation process in their country. 86 of the countries reported using a national curriculum. And just over 56% had ongoing educational requirements. Additional opportunities to participate was also observed. Next slide, please. Next slide, please. So from all those that we have already said, there is a need for investment in midwifery education. From the presentation that we have already had on the literature review, there is need for investment. It is very clear. But what we noted and what we observed was that there were very few tools to help prioritize this investment. So what did we do? We needed tools. And because there were no tools, we had to create these tools. Next slide, please. So we created those tools which we could use to identify the gaps and which would help us at least come up with investment ideas. And to do this, we used human-centered design. We involved the regional leaders. We involved the users. We used people. Next slide, please. So at this point in time, I'll call upon Carl just to give us an overview of human-centered design. Carl, the floor is yours. Thank you.
Thank you so much. And I'm so excited to see that you guys are already employing human-centered design to solve problems. It's a methodology very close to my heart. 16 years ago, we started Africa's first human-centered design firm. We're based in South Africa, but we work throughout the continent. And I've been invited today to share just a little bit of what is human-centered design and what are our experiences and how might some of that be relevant to the amazing work that you're doing, bringing new life into this world. Can we go to the next slide, please? So I'm often asked, what is human-centered design? And the answer is both simple and I think intuitive to understand. And what we will do if we were all sitting in a room is I would make you take off your shoes and pass them to the person next to you and have them put them on. In essence, human-centered design is exactly that. It's learning to feel like what it's like to wear someone else's shoes, to be in their shoes, to understand their life experiences. Human-centered design is both an action, meaning it's a verb, and it's a noun. Let me explain. So human-centered design is a methodology. It's a way and a philosophy of approaching problem solving by understanding those people who are closest to the challenges and all of the influencers that impact your ability to engage and work with those people. As you were talking about in the previous conversation, you need to talk to the expectant mothers, but you also need to talk to their partners, husbands. You need to talk to the mothers-in-law. You need to talk to the religious leaders. You need to talk to the funders. You need to understand what everyone's role is, what their attitudes are, what their rewards are for the work that you do, and what their concerns are. The solutions that arrive from this process are human-centered design. Design meaning that you've thought carefully about that solution, you've taken into account all of their issues, you've involved them in co-creating these solutions. And in fact, this is a human-centered design. It is a solution that is put people at the center of it. Can we go to the next slide, please? The name of my company is Matchboxology, and we do what lots of human-centered design consultancies do in terms of this methodology. We break it down to explain to people that it has 5 basic steps or processes. The first is understanding the evidence. What is the research telling us is the challenge, is the problem, is the gap, is the need? The second is this process of wearing other people's shoes. It's building empathy for all those people involved in what you're trying to achieve. And we do that through conversations. We go out to where you guys work and we listen. And we listen with humility, not assuming we have the answers. The third part of our process is what we call eureka. Eureka being, aha, this is the solution. And in human-centered design, there is a very strong belief that the people closest to the challenges or the opportunities should be at that table helping you solve the problems. So human-centered design is very participatory, and it should be familiar to you guys in terms of using that style of problem solving. What may separate slightly what we do from others is that we don't assume people will always have the exact execution of that solution, and that's where technical experts play an important role. So in our problem solving, we include technical experts to help build on these nuggets of ideas that emerge from these Eureka workshops and make them feasible, viable, as well as desirable. What comes out of the Eureka workshops is what people want. It doesn't always mean that that's going to work out in reality, and that's where technical experts play a really important role. The last step in the process is understanding that you never stop evolving. You never stop getting better. Let's go to the next slide, please. Thanks. So how can human-centered design contribute to the work that you guys are doing? Well, first, it helps you design the right things, meaning that you're actually solving the real problem, not just what maybe research has told you, but you've listened to people tell you and embellish your understanding of the challenge so that you can sometimes see a problem that appears one way is actually a different problem when you're on the ground. And that's the problem that you would wrestle with. It also helps you solve by designing things correctly, meaning that you've got people who are on the ground working with you hand in hand, who are going to help you solve those problems. And in fact, they're going to help you not just solve them, but they're going to refine them and help you implement them. So they're going to have a passion because it's partly their idea too. So human-centered design makes sure you're focused on the right problem and that you're solving it in the correct way, in the best way that has the highest probability of success. Let's go to the next slide. There are 3 basic ways that human-centered design engages these people. So the first is an audience-led design, meaning that people from a very specific audience make the decisions on what the problem is to focus on. They're often the facilitators as well as active designers or problem solvers of the solution. And they may or they may not have guidance from experts. Sometimes you just need to put people in the room and give them this power and they'll do amazing things. The second approach is an audience-driven design. Unlike the led design, here we listen to people's voices and perspectives, and that those drive the decisions about the interventions, the engagements, the approaches that will affect them and their communities. So they have a voice in the solution. They're actively involved in the process, and they lead key project activities, but they are not responsible for making all the decisions. And that's a difference between audience-led and audience-driven. The third methodology that is sometimes employed is audience-centered design. And that's where we have the specific audience and all those influencers around that participate in the process by giving us input, giving us data, giving us feedback. But ultimately, they're not part of the problem-solving maybe team in the final intervention or the proposed solution. If it's a tool, if it's an engagement style, if it's a communications program, whatever. So 3 different ways human-centered design can work, where people do it for themselves, where we do it together with people, or where people are telling us what's really important to them, and those facts are integrated into how we problem solve. Let's go to the next slide. Okay, this is a lot of fancy theory, and I want to tell you a real story that I was involved with in Sierra Leone. And hopefully it helps bring to light how human-centered design can actually contribute to programs. So we were working on a project in Sierra Leone for the government to help determine how village health committees could do a better job of actually delivering better health to their villages. As part of our exercise, we went around to talk to some of the different nurses in the government clinics. So I drove up with my interpreter to this particular clinic. And my interpreter is the one on the right-hand side in this photograph, and the nurse is the one on the left-hand side. Now, this nurse on the left-hand side is smiling now, but when we drove up, she was not smiling at all. She was yelling at a very pregnant woman, and she chased her out of the clinic. And my eyes got huge. I was so shocked. And your first reaction is to think, this is a problem. This nurse doesn't belong in this clinic. This is an actual recruitment or a hiring issue. She is not appropriate to be a nurse. But because we were applying human-centered design, my interpreter and I went in and we sat down with her and we just listened while she talked. We gave her some questions and gave her the opportunity to tell us about her life and her experiences trying to be a good maternal nurse to the women in the catchment area what this clinic served. And what we discovered is that this village did not provide, in fact, this catchment area did not provide this woman with a place to live. So she was forced to live in the clinic. So if you look at the photograph on the left, the lady who is making that bed, that is the bed where women deliver babies. That is also the bed where this poor woman was expected to sleep every night. Once we understood that, we understood that there was a problem not with hiring, but there was a problem with the way that government was placing nurses and what expectations or responsibilities should have been given to the village health committee to organize a hut for the nurse to live in, something with some dignity, something that gave her a little bit of respite and relief from being in this clinic under the difficult conditions, serving all these women. Had we not applied human-centered design, we would never have understood what her reality was. We would never have given her that opportunity to tell us that story. And I think it's so important that you ladies are so close to the challenges that exist out there. And you understand who the important role players are in that. And if you can bring that kind of methodology, but that kind of objectivity, listen to people's stories, understand and appreciate that they all have shoes to wear, and that the more we understand what life is like in their shoes, the better problem solvers we will be. That's the essence of human-centered design. So I hope this has helped a little bit. Thanks for letting me present. I think that's it for me. I'd love to turn it over to Poulet to carry on this lovely meeting.
Thank you very much, Carl, for giving us such a valuable context. It makes us also reflect and self-assess whether we are really audience-centered or not. Now I'd like to call upon our leaders again, specifically to tell us what it was like to engage with their peers in the regions. They should just talk for a few minutes. Just tell us how it was to engage with your peers. We can start with Heloise. Each of you is just going to speak for a few minutes. How was it like to engage with your peers? Heloise?
Can I start in case she's having some challenges?
Let's give her some few minutes and see if she has some challenges.
Okay.
Is Etta here today, this hour? Etta?
Yes, Etta is here now. I had some challenges, so I had to miss out on the first hour.
So are you ready to start the discussion?
Well, I could.
What would you like to engage with your peers during this project? Thank you.
Very good. When we started this project, the first part of it needed us to do some form of inventory of schools in our region. So we had to really go out wide. There was the need to call small number of us together, form committees to be able to fish out the information that we needed. It wasn't that easy, but eventually we were able to do that because we were able to identify the key persons and the key organizations that needed to provide us information. For the West African College of Medicine, we worked at the country levels. And so right now I'll speak in context to Ghana. At the time, because we needed to have the number of schools, we needed to actually link up very closely with the regulatory body that had all information about the schools, about the number of schools that have been accredited to run, the number of schools that were running that had not renewed their accreditation. In Ghana, accreditation is renewed every other year, and you need to put in certain funds to be able to pass. So we had all that information. Again, we needed to do the SWOT analysis, and that was also another difficult thing. We had to pull ourselves together, had a lot of discussions, and then we agreed and disagreed, and eventually we came up with the SWOT analysis that reflected our country and for all the other countries in the West African College of Medicine. That's how it went, and we all pulled our information together and then we shared. And then we moved ahead and we all contributed and participated when it came into the development of the educational capacity framework. I don't know whether I've made any meaning. with what we went through as we did engage ourselves in the region, within the project that we are presented on. Thank you.
Thank you so much, Etta. Can we have our other regional leader, Heloise? Okay, we can have Q while Q, can you go ahead?
Okay, thank you. Can you hear me? Hello.
Yes, we can.
Okay, thank you so much. I'm asking because I have some challenges here of being on and off and so on. Yeah, just to share with how we engaged with our members, our colleagues, like I can just briefly say ECSACON has 16 member states. It's quite a big region, and it's not always easy when you are that huge. But we are fortunate enough to have had an experience some years back when we were working with CNMF on the project of the Africa Regulatory Framework. That exercise taught us to work, to engage the leaders in each country. So this team of leaders, we call them the quad. That is the four. This quad means the NNA president, the regulator or the registrar, a representative of the training institutions, including university, and then the chief nursing officer or director of nursing. So these four people are always the team that we start with in every country in our region. When there is something, we inform the parts of the country first. Why the quads? This quad works like this. The NNA president, as we know that they have a large follow-up of members, union members or association members. The representative of education represents the nursing training colleges and the university, because we have only one university here, which is training nurses. And then the chief nursing officer also engages the ministry, the peers, the director of anything that the college is doing. The regulators, we all know that nursing and midwifery is a highly regulated, these are highly regulated professions. So we cannot do anything without them. So how we engaged them was that when we started this, we informed them first, and then they also had to understand exactly what we needed. As we went on now, when we are going through other things, now these four people will engage others. That is, the registrar will inform the chairperson or the chairman of the Nursing and Midwifery Council. And then the director also engages, and the NNA president engages, the representative of training institutions engages. So when we were now going into the deeper details of the exercise, it was easy to bring in other additional members. For example, the training schools. The training schools, we engage them through this representative to say, this exercise on pre-service midwifery needs the midwifery schools to be engaged. So that's how we ended up bringing them in, because we needed their expertise in this exercise. We couldn't do on our own without them. So that's how we engaged them, and then they kept on coming. When there was a topic that needed a certain expertise, then we will draw them to the meeting. We come with them, they share their views. Then the next time they can continue with us, or if there's another topic, we bring those with the expertise in that area, and then we bring them to the meeting. They also share their ideas. So I think I can just say, by so doing, it makes everyone to be engaged. Whoever is needed was engaged. So I think I can just be as brief as that.
Thank you so much, Kyo. We will have Heloise.
Louise mentioned that she is having some technical difficulties with her sound. So I've asked her to restart, but maybe we can move on, and
yes,
she's able to restart and join, she can add.
Thank you so much, our regional leaders, for such experience. We have really, we now know how the project was done. We have also heard from Carl telling us about human-centered design, and we have just completed the experience of our leaders. I'm now going to discuss how we developed the frameworks. We call these frameworks educational capacity framework. And this educational capacity framework, or ECF for short, is a tool that can be used by stakeholders to describe the current capacity in key functional area. This information can help prioritize investment if needed. Next slide, please. We decided to choose these frameworks because they have been successfully used to advance nursing regulation in ECSACON. I think we have already heard from the ECSACON regional leader that they had used the frameworks before for regulation. This information will help prioritize investment. Next slide, please. How did we develop these frameworks? We used an interactive process. We drew upon the group's experience, and I'm sure you have heard the regional leaders how involving and how much they involved their workers in the region. And this is how we developed we used an interactive process to create. We drew upon the group's experiences, and we focused on the key domains that we have seen on the model that we talked about, which are clinical practice side, the students, faculty, curriculum, and infrastructure and management. Next slide, please. And we are now getting to the anatomy of the frameworks. So the frameworks will have a function. The function will be on the right, on the left. And then it also has the stages, and the stages on the right. As we can see, we have the students there as a domain, and the students domain have got some functions on the left there. Like for the students, we will need to admit or select the students. Academic and non-academic support service will be another function. The students' rights and responsibilities will be another function, and the recruitment will be another function. Next slide, please. So in other words, The functions are on the rows of the table on the left side, and the stages are on the column of the table on the right side. Next slide, please. And for the stages, we have 5 stages or levels: stage 1, stage 2, stage 3, stage 4, stage 5. And for the functions, you can have as many functions as you can have. Next slide, please. So what are the functions? Next slide, please. Core processes or sets of activities that you carry within the domain. For example, we have seen on the students, and what we carry on that domain of the students is selection, admission, and selection. That is what we carry on that domain. Next slide, please. The stages are the points in the processes towards maturity. If it is stage 1, it's less mature, and it is stage 5, it's more mature. Or we can also call them levels. Level 1, level 2, level 3, level 4, level 5. The stages of maturity or towards maturity. Next slide, please. So we have already talked about that the frameworks are created and they have functions at a time. You identify the functions and you work with the function, for example, just like admission. Then you begin to draft what the different stages would look like. You have a domain like the students, and you come up with the activities that you do within that domain, like admission and selection. So you identify this function within the domain, and then you begin to draft the stages, the processes, like stage 1, stage 2, stage 4, stage 5. The least mature will be stage 1, and the most mature will be stage 5. Next slide, please. And when we are developing this tool, we used a tool called the Jamboard. And this is an example of the Jamboard. This is the function of the student rights and responsibility. And we'll define what that is as a function. And you can see the stages there: stage 1, stage 2, stage 3, stage 4, stage 5. And the leaders, together with the workers, will come together, throw ideas as stage 1. What will the stage 1 entail? For example, I'll just take stage 1 of the students, the student rights and responsibility. And then the stage 1 here is processes and policies either do not exist or are under development. This is what we can say. It is stage 1 because we say they are under development or they are not under use. Students are not included in school committees. This is one of the levels under stage 1. So we use the Jamboard, which is a tool, and this is just an example of the tool. And we can show the example of the tool for our French participants. Next slide, please. So that was the one in French. Next slide, please. Now let us try and see what we can be able to do. Let us use our experience. Let us have our providers. Next slide, please. So we are going to try it. We are going to try to do this domain. We are going to use a Jamboard. We are going to try out the Jamboard, and we are going to use the clinical side as our domain, clinical practice side. And we are going to use the sample function as the clinical site selection. So the clinical sites is a function because the processes and activities related to site selection are critical. Now, what are we going to do? How are we going to try it? We are going to try and see what are the stages of the clinical site selection. And we are going to try and use the Jamboard so that we can see what the Jamboard can do for us, or what the Jamboard did for us.
And I can quickly share my slides to show the example Jamboard. I've also dropped the link for this Jamboard into the chat box as well. So please give me 1 second as I try to pull up.
So Anam is going to show you how to use the Jamboard, and then you are going to use the link on the chat to try out the Jamboard. And you are going to use the clinical site selection on the Jamboard. You want to come up with either stage 1 or stage 2. What would stage 1 look like? And we are saying the stage 1 is the least mature, and stage 4, 5 is this most mature.
Great. So the Jamboard functions are fairly simple to use. I'm actually going to, I know I see somebody is moving these stages. I'm just going to move them up just for a little bit so I can provide a quick demonstration on how to create these handy little Post-its. So give me 1 second. Sorry to the little squirrel that's trying to organize this for us. So let me just push this back up. Okay, so in order to create a stage or a sticky note to add your thoughts for how each of the stages develop for the clinical site selection, you would on your left-hand side see a toolbar, and on that toolbar you'll see a sticky note feature. If you click the sticky note feature, you can type in your response here, and you can also provide it in different colors if you like, and then hit save. And from there, it will save your response. And so then from there, you can click and drag and put it into the most appropriate stage as Palelo described. So I'll stop right there and I will hand it over to Palelo. And if you need to edit your response, you can edit the response on the top right corner. I'm going to go ahead and delete this response right here. Great. Over to you, Palelo.
Thank you so much, Anam, for that showing how to do the Jamboard. Now I want us to try out the Jamboard. There is a link on the chat. If you can just open that link, you will get to the Jamboard. And the clinical site selection is our function. And I want us to write either stage 1 or stage 2. Just try out that and let's see what you can have. And I will call upon Francis at that time to get ready at that time so that she can talk about the next session.
Thank you, Palelo. Perhaps if people have their if we could look back at the slide, which shows, I don't know if has everyone been able to access the Jamboard? The link for the Jamboard is in the chat. And as Palela was saying, this is the process that we used to engage all of the partners in deciding what the steps would be or what the activities would be to determine which stage the school is at. So if we are not asking that you know each and every stage or each and every idea, but just to give a sense based on your experience in pre-service education, what might be the activities or the description in stage 1 or any of the other stages. And I wish we could have that slide back up, which showed the various stages for the example that you gave. So we just asked you to spend a couple of minutes looking at and just taking a guess at what might be an immature state, an immature issue or a process in terms of level of maturity for each of the different stages. So for example, someone has written medication, equipment, and other stock materials can easily be transported to the clinical site. So go ahead and write what you think. And if you'd rather just watch, that's fine too. But we just wanted to give you an example of what we went through painstakingly to ensure that each of our partners were driving this process and using and determining the stages based on the existing realities in the various schools. So please go ahead. We'll just give you a couple of minutes. I know some of you have used Jamboard before, others may have not been able to use it before. This is the first time. It takes a minute to get used to how to put the stickers on. So please do go ahead and take another minute or two. But this is part of the human-centered design, part of the iterative process that we use to develop the educational capacity frameworks. And it was a fun process. It was a tedious process. It took weeks to develop each domain. It was not a simple process. And sometimes as our partners went back to think about it, they would come up with changes or other revisions for the stages that, for the various domains. So thanks. I see some are already starting to populate the Jamboard. Please do go ahead. We'll give it another minute or two, please. There's some very good points here. Only a small percentage of community can travel to the clinical site. So travel to the clinical site is very important. There's no adequate space for students and staff. And this is a very, very common issue, you know, where particularly in places where there's competition between medical students and midwifery students, for example, medical students often have priority in terms of being able to attend births or being able to attend the clients that need assistance. So very often nursing and midwifery students are at the bottom of the rung when it comes to getting experience. So that's a very, very important point. Accessible for students is very, very important. If a clinical site is not accessible for students, then it might not be the best place to select. The site has trained police preceptors, also an excellent point. What, you know, if a site does not have the preceptors, then the students often have to clamor for attention from other preceptors that might be there, or for those who have not been trained to precept the students. Resources available, sheltered from bad weather. Thank you for all of these great inputs. Determine if the site meets standards of excellence. Wow, what an excellent point. Because very often site selection is focused on, you know, the number of clinical experiences available, but not for the quality or standards of excellence. Very good. Thank you. We appreciate you putting in. This is the exact process that we went through when we were developing these ECFs. Sorry, Palelo.
Thank you so much, Francis, so we are seeing the stages. So what would happen after throwing those points together? We would come together and now try to synthesize, really make sense out of all that was thrown onto the Jamboard. Thank you so much for all your input. That is very helpful. We will look at them and see what we can adopt and what we can work on. And for you to continue, Francis, just to give us an overview how what we have developed can complement what is already available. Thank you so much, Francis.
Thank you, Palelo, and thank you all for your participation. We do want to emphasize that, you know, although we've developed these ECFs, as Palelo mentioned earlier, there are similar educational capacity frameworks or capacity frameworks for other aspects, such as regulation. And we did develop these not for the purpose of ignoring or replacing any other assessment tools that might exist. For example, the International Confederation of Midwives has developed an extensive midwifery education accreditation program that is designed to accredit schools or certify that they do meet the ICM standards. It's partially a self-evaluative process, but it also is much more extensive. So this is not meant at all to replace that or any other assessment tools that are out there. Next slide, please. Next slide. Oh, so again, you know, as I mentioned, there are other assessment tools. For example, JPIGO has a rapid assessment tool, which also goes into looking at specific things like infrastructure and many of the same domains. Again, this is not meant to replace that, but in fact, it can be complementary. Next slide, please. So overall, the ECFs that we've developed are designed to be used by internal stakeholders. So, you know, actually a self-assessment process that may not be facilitated. And it's meant to provide a quick overview of current capacity for the various schools that will be using it. If there is an accreditation process that the school is undertaking, this is something that can be used very early in that process to help schools identify and highlight their own areas or gaps for investment. And then lastly, and importantly for many programs, is that midwifery education overall is quite a large area to think when we think about investment, when we think about where a supporter or a funder might look to assist. And so when we say we want support for midwifery education, what area of support, what specific area can we invest in so that over time we see that this is a useful investment. This is an area that is important to help the school grow or to help the school progress in maturity in these different stages. And so we think that this exercise can really help target investment information for those supporters or funders that may be looking to where specifically they can invest the limited funds. And we all know in this space that more and more funding opportunities and resources are continually decreasing and continually becoming limited. So investors and funders are looking for very specific ways in which they can make a difference. And we think that this tool can be one of those things to use to provide a general overview and then some specifics of where they can focus their investments. Thank you. Next slide. So that was quite a lot to go through. We hope that you have a basic understanding of how we developed these tools, or how we developed this tool to utilize with the schools. We are in the process of field testing these educational capacity frameworks. But for this discussion, we'd like to ask you if you have any questions, or if there's anything that you'd like to understand better. Please do drop your questions in the chat. We'd be happy to try and answer them. We realize that this is a lot of information to process. We hope that we have been able to give you a much better picture of how we proceeded in this particular effort. Thank you.
Yeah, Francis, there's one comment in the box so far that this is a great exercise. They wondered if an iteration of this might be not to think about 5 stages at the beginning, but just think about themes about what makes a good site and what makes a bad site. And then a second exercise is sort of map them out.
That's a very good point.
Yeah.
That's great.
Yeah, I think that's a good suggestion, actually, too. I think it can be difficult to sort of figure out the 5 different levels initially, but
that's really good feedback. I think that that's something that we could think about, to have kind of an overall, like what would make a good site selection, or it's a similar question for the other domains. Thank you. I think there's another question, Nancy. Let's see.
Oh, the 4th stage is consistent with the ICM standards. Why wouldn't that be stage 5?
Great, that's an excellent question. It's actually one that we grappled with, isn't it, Palelo? Yes, and this isn't meant to, I can start, and perhaps Nancy, Palelo, others, you can perhaps add to that. One of the things that we grappled with whether or not to make the most mature stage that which was consistent with ICM standards. And we went back and forth about that, but realized that the ICM standards are meant to be the minimum that one would have in place for a particular domain. And so we realized that in some instances, for some of the domains, that many schools are going beyond the ICM standards and instituting things like ensuring that information for that particular domain is digitalized, or records are digitalized, and it's available on their website, or available to the public. And so we decided that since, again, we are not ICM, and we are not trying to accredit to ICM standards, that the ICM standard would be ideal, but that to acknowledge and to recognize those schools that have gone above and beyond to the next stage. So that's an overall response, but Nancy and Palelo, I'm sure you have other things to add to that.
Well,
I think you have addressed it very well. Because
yeah, I think so too. I think it was, yeah, it was sort of, yeah, having the capacity to go beyond those standards that I think they thought could be generally met by most schools of nursing, to maybe then really have standards that were really high level of standards of excellence. But I think, Francis, you did a nice job addressing that.
Thank you so much, Francis, for that and for leading the Jamboard. Let's move on. Anam, I think it's probably break now.
Yes.
And go ahead and announce the break, Anam.
It is time for a break, and we will take about a 5-minute break to stretch our legs and grab some coffee, and we will be back in about 5 minutes, so starting at 2:05.
And we really hope people come back, because we're looking forward to feedback. It's more interactive component. So.
Yes. Our next half of our session will be very interactive, where we will introduce our pilot testing with our schools.
Welcome back from your break. I hope you had a good time. And For those, I can see we are now less, but thank you for those who managed to come back. I would like to share how our project is progressing, and I'll also have a chance to invite you to try out some of the tools that we developed. Before we try out the tools, let me just give feedback. Let me just explain where we are in our project. We have, like I have said, we have developed the tools, ECFs, 5 of them, like we have been talking about them. So we have created those framework for those domains, and now we want to test them just to see whether they are useful to our schools. We are testing the tools, as someone has already mentioned, in our 3 countries, Botswana, Togo, and Ghana. These are the countries from our 3 regions, like ECSACON, the West, and the French. We are collecting qualitative and quantitative data, and we are collecting feedback as we are using these tools. The schools, as they are using these tools, we are hoping they will identify the gaps and develop an investment plan. And hopefully, they will be able to initiate change after they have developed the investment plan. We hope they will be able to initiate change that will help them move towards excellence. We know that our schools are not schools of excellence at the moment, and we know that, but the wish is that they should move somewhere when they initiate the change. So we are field testing the tools that we have developed in the 3 schools in our 3 countries, and we are collecting feedback as we are going on. And with the gaps that we identify, the schools will develop an investment plan with the hope that they will be able to initiate change to move towards excellence or to improve the education of midwives. Next slide, please. Now, I'm going to, Etta can join me. Feel free, Etta, to join me when we are doing this exercise and just to work with me. Even you, Keo, feel free to chip in as we are moving towards now implementation of the frameworks. So we are going to work, we are going to break now into groups. Maybe I'll ask Anam to explain our next exercise.
Absolutely. So in our next exercise, I have sent a link to a Google document, which is our ECF worksheet. And we encourage that you open up that document. You may also download that document and work on it for your specific school. In a moment, I will open out 3 breakout rooms, one for Francophone West Africa, another for Anglophone West Africa, and a last one for South, Central, and East Africa. You may choose which breakout room you would like to go into. And with your group, you can practice on the worksheet. There's one for English and another for French. You will have about 15 minutes or so. And as we get closer to wrapping up, I will make an announcement in each room to wrap up. Once the worksheet is complete or near completion, we will come back together and have a conversation about it. So over to you, Playlo. Please let me know when you would like the rooms.
Thank you, Anam. And Keo can join the ECSACON. Etta can join the West. and Heloise can join the French. Now we are ready for the group. So read the instructions, try to complete the worksheet, make a note of what is or what is not clear. So after that, you are going to give us feedback on what you tried out. Thank you so much. We will join you in the groups. Okay, maybe we can have the West just share with us what was it that was useful, what was good about this worksheet, what was clear and what was unclear, and what do they think they can improve, and is it useful? Do they see it useful in our schools and in our disciplines? Can we have the West share, debrief? ETA's group?
West English. West English.
Yes,
Thank you.
West English, sorry.
Yes.
Sorry. Because we
Thank
also
you.
have the French,
West
the French,
yes,
West.
francophone.
Yeah, let's
yes.
have the French, the English.
Okay,
share.
first.
Yeah, we've lost
So
our
English,
interpreters.
okay, very good. Okay, so for West English in the group, I had two of the participants who were actually not NESN, but they were in the program health, and so they are in here to learn. So I started off trying to explain what the ECF details, what it was for them to appreciate, until we had some others join. We had a nurse midwife, we had two nurse midwives, and one was a teacher, a tutor. So that was at that point that we're able to now go into using the tool. Going through it with one of my participants who is from Nigeria. She looked at the various stages. We did just the first level, first function, the clinical site selection, and she was able to check off all the points, all the boxes under stages 1, 2, 3, and 4. We got into stage 5, and she realized that within stage 5, she was able to check off 4 of the boxes, except the last one. And the last one was to do with the facilities having available, the practice sites having skills laboratories available. I didn't ask them these questions, but from discussions that went on and the responses that came, I could see that it was a tool that was understood and was appreciated, because at least whilst answering the questions, she was able to tell us that my school had this, and so I can place us at this level. And I think we are into that next, and then that and that. So it was quite clear for them. I never had the opportunity to ask about how we could improve the use of it. We had very limited time. And so the last 2 points I would leave unanswered. But I should think that, in my opinion, and from the explanation I gave to her and to the group, as to the last point that was not checked off, it became very clear that this tool is there to guide us as we plan and prepare to train the midwives, ensuring that every little thing that needs to be in place to ensure that the midwife who is being trained is trained in a way that she's able to acquire the skills and the level of competency that she needs to have before she joins the workforce is made available. I think that's when I hit on. And so somehow in answer, but the use improvement of the use of the tool, please, I never asked about that. Thank you.
Okay. Okay, thank you so much. Any additions from our other colleagues, the ECSACON, if there is anything, and very brief, if the French also just very briefly to add, if there's anything that is pressing them to share with the group.
Actually, there isn't anything to share with the group. I think the way they did it, but the only difference is with them, at least they were with a lecturer there. I think if I heard well, but in our group it was only myself. I'm not a lecturer, I'm just a clinician. So I just had to put myself in the shoes of the lecturers. But when I looked at it, I just used my experience with our training institutions and the size. So I only ended up at level 5. I found that quite like 3 boxes they were not fitting. So I went back to level 4. So I felt that I was in level 4. But otherwise, I think I did it the same way they did.
Okay. Thank you so much. ECSACON. Anything from FASFAF? Just one addition if there is anything, and if there is nothing, feel free to let me know so that we move on.
We also do not have interpreters, so if anyone who is bilingual would like to make any comments, please let us know. Thank you.
Thanks, Francis.
And Craig, if you're available, if you don't mind translating what Palelo just asked for the larger group.
Okay.
Oui, s'il y a quelqu'un s'il y a des francophones, si vous avez des commentaires à ajouter, maintenant c'est une bonne opportunité de le faire.
Thank you so much.
Okay. Thank you.
So should we move on now, or? Let me just thank you for this exercise. You've given us some inputs, and I think because some of you can continue in their countries to look at it, in their regions to look at it, and continue giving us feedback if you can. This is a working document, it's not yet finalized, and we are going to be improving it as we move on. And thank you very much for those input. So, and feel free to share any additional information from your region, or to share with your region anytime. Or if you have any input even after the conference, feel free to send to the email below. If there is anything that you feel you want to share related to this worksheet, feel free to do so. So let me take this time now to thank you all for your input, and call upon Francis and Nancy to give a summary and closing of the conference. Francis, and then she will call upon Nancy. Thank you so much. Over to you, Francis.
Well, I thank you, Palelo, and I wish to thank all of you who have decided to hang in there for this quite lengthy session. We really appreciate your participation, and we value any feedback, as Palelo said, that you might have, or questions on any of the sessions or any of the components of the session. And certainly in particular, if you might have any feedback on what we are working on with the continuing progress for the inventory, the inventory for the midwifery education programs in Africa, or certainly for the educational capacity frameworks. We are hoping that these frameworks will not only be utilized for midwifery programs, but that any pre-service education program could adapt to them and revise them accordingly for use. So we're looking at this eventually as a tool that can be used overall in pre-service programs. Next slide, please. So just in summary, you know, we all realize, and I think certainly those of us who are involved in pre-service midwifery education realize that there are tremendous challenges. They are substantial and they are not going to be solved or resolved overnight. We also concluded that new approaches are needed to prioritize investments. Again, with the increasingly limited funding and increasingly limited resources, we must be more specific and more detailed in how to prioritize investment areas for supporters and funders. And that the human-centered design approach that we used and that, or any human-centered design approach focuses efforts on the needs and the realities from the perspective of the audience. So we encourage any efforts to use such an approach. And as I mentioned, although we used these for midwifery educational leaders, they can be designed for any pre-service program, but they were not developed by JPIGO or the Momentum Project or by Johns Hopkins School of Nursing. These were developed by the midwifery educational leaders in the region, and they have been a substantial part of each and every aspect of this work. So for the ECFs, a pilot is ongoing as we speak. The various schools in Botswana and Togo and Ghana are meeting weekly to go through in detail with the leadership of that school, each of the worksheets for the various domains, the ECF domains. And so we look forward to sharing the end product when it is complete, where we will gather information in terms of the experience in using these frameworks and what the results of the frameworks exercise. We look forward to sharing them with you, but in the interim, please do feel free, as Palelo has mentioned, to share your feedback, any ideas or any feedback or input that you may have. We welcome this. Again, these are works in progress. They are living documents. We are working to see how they might be used and what can be done better to improve them. And we have other countries that are currently interested in also that are even not a part of this project that are interested in utilizing these frameworks. So we do welcome your feedback. You are the ones that are working with educational institutions around the continent. So we appreciate any questions, concerns, feedback, or input that you might have. We do appreciate you again taking this time. We thank you for your attention, and we do thank you for joining us until the very end of this program. On behalf of all of our partners, on behalf of all of our team, we thank you very much, and we look forward to continuing to hear from you and also to continuing to provide input and results as we receive them. Thank you very much. Nancy?
I have nothing to add. That was a terrific summary, Francis. So again, I'll just reiterate your thanks and really appreciate everyone's participation today. So be well. Thank you.
Thank you. Good day, good evening, good night, everyone.